Yeah, it should be okay. Okay, what do I need to do?
Nothing.
Nothing.
All right, that's even better.
I was going to get these out after you. Unless you want me to. Okay, so we're a minute past. But it's my pleasure to introduce Miss Natasha Reeves. She did her undergraduate at Lipscomb in Nashville. And got her undergraduate degree in molecular biology. And I still remember the first conversation I had with you in VCME first year because you told me enthusiastically how much you love medical genetics. And I thought, oh dear, we're going to kill that enthusiasm in her because the term's just starting. No, it didn't. And she went on to do some really interesting work with something that not a lot is known about, which is Factor V Leiden. And in addition to being a nice science nerd, she's also a talented artist. She sings. She works in all sorts of different painting and drawing and amazing things. So I want you to take it.
All right, hello. Like Dr. Baker said, I'm Natasha Reeves, and before I get started, I wanted to go ahead and thank you all for your loyalty by passing out my little blood cells here. If you please just take one, but if you're having a really bad day, take 2 or 3. And if you'll see back there, I've got an Avengers cup. Put all the extras there. Well, there was no choice. It was only sugar-free. It was very, very disappointing, I found. Alrighty, so my non-thesis, I focused on Factor V Leiden, as Dr. Baker said, but my non-thesis is entitled The Fibrinogen Gamma A/Gamma Prime may provide an effective treatment of venous thromboembolism due to activated protein C-resistant Factor V Leiden, which doesn't sound that exciting. I think when I get done, maybe you'll find it a little bit more exciting than it sounds. Right now, it just sort of sounds like a jumble of scientific terms to make myself sound smarter than I am, which I promise I'm not going to be doing. So, a little bit of an overview on why clotting is important. It's very important, in case you were not aware of that. It does preserve life from day to day. And if you were like me and this poor little fellow over here, you fall all the time. I fall into things, I slip, I stub toes, I get bruises that I have no idea where they come from. And if I did not have my clotting system and my clotting factors, I would have been dead before the age of 1. So it really is very important. It does keep you from bleeding to death. That sounds a little bit dramatic, but it is very true. But it also prevents the sort of a little bit more minor complications of shock and also other hemostatic complications. And it also keeps you from clotting too much, because even though you're forming a clot, and that's really important, you don't want to over-enthusiastically form a clot and all of a sudden have this ginormous thing in your blood vessels that you really do not need. And it also is very important with healing, especially with all of the bruises that I've mentioned. I actually don't have any on my legs right now. I'm very proud. I was trying not to run into things so I would look very gorgeous for you all. And it also is really helpful to understand the clotting cascade and actual individual clotting factors for planned procedures such as surgeries and other different types of things, because everybody clots a little bit differently, but sometimes you really do need to be aware that there are certain diseases and chronic complications that do affect the clotting cascade. So you do need to be aware of that. So clotting is very, very important. So this is just a pictorial representation of what normally people think of when they think of the coagulation clotting cascade. And this is a very complicated looking picture, and honestly, I'm just going to briefly say a couple of things, and then I'm going to show you the real way that I understood the clotting cascade, which is actually a whole lot different. That is based on the cell-based thrombocoagulation. But if you'll notice the Roman numerals, they actually represent proteins, and each one of the arrows is an enzymatic reaction. So we are having a lot of proteins that are doing enzymatic reactions with one another. The majority of these are serine proteases, which cleave and activate other of its brethren and stuff like that, and so on and so forth. But I want you to really notice that at the end of the day, it's really important that we end with actually making a clot. So that's really all I'm going to say about this particular figure. So the cell-based model of coagulation, it has 3 different stages. It's got initiation, amplification, and propagation. And it's sort of was, I guess, not necessarily common knowledge, but everybody just sort of assumed, everybody understood this particular, this cell coagulation-based clotting from the picture I showed you before. And honestly, even though both of them are correct, this temporally makes a whole lot more sense in my personal opinion. You do, with a clot, you do begin with tissue factor. And tissue factor, basically you're beginning with a vascular injury, because tissue factor normally is not shown or seen by the actual flowing blood through the blood vessels. So it's not seen unless you have some sort of injury. And when you have some sort of injury, all of a sudden the tissue factor is exposed to the flowing blood. You have a lot of your factors are always flowing in your blood in their inactivated states, and factor 7 is one of those that is specifically looking for tissue factor, so injured places in the vessels. And so factor 7, if it sees tissue factor, it will bind to it and it will autocatalyze itself, which is just basically saying it will cleave itself. And from now on, if you see a little a after the factor, so factor 7a, that means that it's activated. And it really gets confusing when I say it's deactivating, activated, factor such and such, so I'm just going to say a from now on. That way you guys don't get quite as confused as I made it yesterday. It was really interesting yesterday. But this particular binding with factor 7 and tissue factor, after factor 7 autocatalyzes itself, it forms this complex, which is the tissue factor 7a complex. And this activates a very small amount of factor 10 and factor 9. And factor 10a activates a very small amount of thrombin. And thrombin is also known as factor 2, which is why you see that little pause sign up there in that figure. That actually is representative of 2, and it sort of is known either way. Mostly, if you think about factor 2, you're talking about thrombin, and you say thrombin. So now we're in the amplification stage. And again, I want to reiterate that this little bit of thrombin that has been activated is not enough to make a full-blown clot. It's just enough to sort of grease the wheels and get this whole thing going. So this small amount of thrombin activates factor 5, factor 8, and factor 11. Factor 5a is a necessary cofactor of factor 10a. And factor 11a is necessary to produce large amounts of factor 9a. And factor 9a, if you'll recall, is, well, I'm not sure if you'll recall because you only saw the picture for a brief moment, but trust me on this, factor 9a will actually, 9a and 11a will eventually start making a whole lot more of factor 10, which is the main player when we're trying to make thrombin. Factor 8a is the necessary cofactor for factor 9a, which makes factor 10 with the thrombin. Sorry, jumped the gun there. This is basically essentially priming the system for actually churning out this actual clot, because even though this sort of seems like it's a really slow process, it really is not, because once you need a clot, you need a clot. And so in order to make sure that there are no snags along the way, the system needs to prime itself so that way when it's clotting, it will clot. So we're still in the propagation stage, but factor 8a binds to factor 9a, and this forms the tenase complex on the platelet surface, and this is what activates a large amount of factor 10a. And factor 10a binds to factor 5a, which is what I'm interested in. Generally speaking, factor 5 is really what the talk is all about. And this forms the prothrombinase complex, and the prothrombinase complex activates a large amount of thrombin. And I'll go into the prothrombinase complex a little bit more. Okay, so the prothrombinase complex is a little bit like Avengers Assemble. You need multiple guys coming together in order to get something done. And none of these on their own really is very efficient, but together they're very efficient. So we have, it involves factor 10a, factor 5a, prothrombin, and some calcium. And this is formed normally on activated platelets that are around whatever platelets it can find, but it has to have calcium in order to work. And this particular prothrombinase complex catalyzes the formation of thrombin 300,000 to 1 million times more than factor 10A alone. And this is actually the cause of the thrombin burst. And this thrombin burst is necessary in order to make a clot quickly and efficiently. So sort of back to propagation, I sort of went a little bit sideways just so you guys could see the prothrombinase complex because it is very important with Factor V and Factor V Leiden, which I will mention in a moment. But the cell-based, the propagation, thrombin, now that we're making a ton of thrombin, it's going to be cleaving fibrinogen. And I want you to remember fibrinogen because it's going to become important in a moment. And fibrinogen is normally soluble, but when thrombin cleaves it, it becomes insoluble and is now known as fibrin. And these fibrin monomers actually will aggregate and form what is known as a soft clot. So you don't really have a mature clot at this point, but you do have the formation of where the clot is going to happen. And this soft clot actually is cross-linked with using factor 13A. And that factor 13A utilizes transglutaminase in order to make the soft clot into a hard clot by trapping platelets within the clot. So now we actually have a bona fide, good, more or less semi-permanent clot, because obviously you don't want it forever, but that's a whole other discussion. And like anything, it's very important, or it's just as important how something begins as well as how something ends. So the cessation of a clot is very important because, like I mentioned before, you don't want clotting and clotting and clotting and clotting, and all of a sudden, oh my goodness, you've got this ginormous thing in the blood vessels. It's occluding. There's all sorts of issues going on with that, and that's just not good. So the cessation actually starts with thrombin, like most things are with utilizing thrombin. And thrombin binds, thrombin is flowing in the blood because the blood is liquid, and just because you got a site of injury doesn't mean that the blood flow is just going to stop. So whatever thrombin that is activated is flowing, and it's going to flow downstream wherever the blood's going. Well, thrombomodulin is on the inside, facing the blood on the endothelial cells of intact blood vessels. So these are the blood vessels that are not damaged. And so thrombomodulin's on the lookout for thrombin, so any activated thrombin, it will grab onto. And thrombomodulin stops thrombin's clotting ability, and this particular thrombomodulin complex activates protein C. And originally it's known as activated protein C, or APC, which I may be referring to interchangeably. APC and protein S form another complex, and this particular complex deactivates any factor 8A or any factor 5A it comes into contact with. So this is helping contain the clot to the site of injury. So you're not just starting at the site of injury and then all of a sudden clotting all the way downstream. That way we can contain the clot, or the proteins can contain the clot to the site of injury. Now, I know you all are thinking, well, this is a factor 5 talk. Why are we talking about factor 8? Well, it's very important, factor 8, because factor 8 and factor 5 are incredibly homologous with one another. They're very similar. They look very similar. They do not actually do the same kinds of things because they are processed differently, but on a protein level, they are very similar to one another. And we have this incredible amount of knowledge on factor 8 and on factor 8 deficiencies, but we don't have that whole amount of knowledge on the factor 5 and its deficiencies. So it's really very important when we're trying to, it's kind of like solving a puzzle. You kind of have to have the surrounding bits in order to figure out where one puzzle piece actually ends up. So factor 8 is sort of like that, the surrounding bits for the factor 5. If you'll recall from not that long ago, factor 8 is a necessary cofactor for the 10ase complex, which is generating factor 10. Factor 8 contains the domains A1, A2, B, A3, C1, and C2. And it's necessary to have the B domain removed if you're trying to activate the factor 8, but it's also for factor 5 as well, which I'll mention again in a moment. And the deficiencies in factor 8 are very well characterized. They're known as hemophilia A, and they have been identified in writings as far back as the 2nd century AD in the Jewish Talmud, which mentions that if a boy had 2 older brothers who died from circumcision, that boy was excluded from the requirement for circumcision. And it's also known as the royal disease. Queen Victoria's lineage, and I believe the lineage even goes into Russia, which I'll talk about Alexei in a moment. You see a whole lot of prevalence in that because there is a whole lot of intermarriage with the royals, keeping the royal blood pure and all of that. Just like poor little Alexei over here, who ended up having hemophilia. I believe he was killed, murdered before he really had a chance to really succumb to the disease, but it is a very prevalent in the royal population. I believe even today it's pretty prevalent. But generally in the general population of us that are not as high and mighty as royals, it has a prevalence of about 1 in 10,000 males. So factor V, that's what mostly my talk is going to be concerned about. As you'll remember, is a necessary cofactor in the prothrombinase complex. Remember, Avengers assemble. And it's incredibly homologous, like I mentioned before, to factor VIII. And does contain the exact same domain names and sort of the way that they are put together with A1, A2, B, A3, C1, and C2. But the B domain does have to be removed in order to activate the factor. It does have a copper ion that stabilizes the heavy and light chain between the domains A1 and A3, and it is secreted as a single chain, non-enzymatic cofactor. It's a beautiful picture right there. So factor V abnormalities, there are 2 different types. Type 1 is a concomitant deficiency of the protein and the enzymatic activity. This includes 75% of factor V abnormalities, and in order to be diagnosed as type 1, factor V circulation of the protein has to be less than 10% compared to wild type patients. And this is very similar to hemophilia because type 1 deficiencies have issues with forming clots. And there is no isolation technique for factor V concentrates, unlike factor VIII deficiencies, because there are concentrates for factor VIII and other recombinant proteins, which is another way that factor VIII can help his buddy out, trying to see if we can find some treatments for factor V, but that's still sort of in the making. Factor V is also not in cryoprecipitate or prothrombin concentrations, and so the main treatment for factor V deficiencies are fresh frozen plasma, which really is a combination of pretty much every single clotting factor you have in the blood of whatever donor donated their plasma. And although it's very important and it does have the factor V, it has all this other stuff. And that can cause a damaging hypertonic environment. So usually, even though it's not the preferred treatment, it's kind of the only one that's available. But there are type 2 factor V abnormalities, and this has normal levels of protein, but altered enzymatic activity of those proteins. So this encompasses about 25% of the factor V abnormalities. So Factor V Leiden is what I was interested in, and it is a type 2 abnormality. About 5% of the Caucasian population has at least heterozygous for one Factor V allele. So that's pretty prevalent, even though the prevalence of Factor V deficiencies as a whole is about 1 in 1 million. Factor V Leiden is way more prevalent than that, which even though Factor V as a whole is considered, if you have a deficiency of it, is considered a rare blood disorder, this can't, when you really look at the facts, it really doesn't seem like it should be classified that way, but for now that is its classification. Factor V Leiden disorder is tenfold more common than all other thrombophilia disorders combined, so it is a big problem. It's a gain-of-function prothrombotic mutation, and it had exchanges in arginine for glutamine at amino acid residue 506. And it's interesting to note that arginine 506 is one of the sites that APC cleaves in order to deactivate Factor V. So just sort of keep that in your mind. Inactivation of Factor V-A Leiden is tenfold slower than its wild-type Factor V-A counterpart. So this basically means that it's resisting the inactivation by APC, and homozygotes have an 80-fold increased risk for venous thromboembolism. And basically that's an occlusion or a blockage of the blood vessel because you have too much clotting, like I mentioned before when I was talking about the actual clotting cascade. heterozygotes have an 8-fold increase. So even just having one allele already increases your chances 8 times in order to develop venous thromboembolism. And venous thromboembolism is also considered a chronic disease because once you have one attack, you are more and more prevalent and susceptible to having an additional attack. So this is a chronic disease that you will have all your life. And I believe I was looking in the literature, and with just one factor V allele, you are more likely to have a venous thromboembolism attack than you are not. So it is really a big deal, even though, like I mentioned before, this is a rare blood disorder. And it has been postulated that perhaps the factor V Leiden allele provided an evolutionary advantage or a heterozygote advantage, especially with childbirth with women, because up until, and I know it still happens, especially in countries with not as much health care, but a lot of the women, when they're having childbirth, obviously you're bleeding because you have a child and things are tearing and things are just going everywhere. And you would think it would be very advantageous to have an allele that made you clot a little bit faster and not necessarily bleed out so much. However, they found very recently, I think within the past 5 to 10 years, that if you have a factor V Leiden allele, just one, 2, forget about it, but just one, you actually have a harder time conceiving a child. And not only that, but you have a hard time keeping the child without a spontaneous abortion, along with other pregnancy complications. So whether or not it has an evolutionary advantage, it's very difficult to say because there's a lot of pros and a lot of cons going for the actual argument. So there really are not many treatments for factor V, Leiden especially, because the prevalence is very high, and there's really currently no treatments for these particular patients. I mentioned the cryoprecipitate and, the fresh frozen plasma, and yes, that works, but it doesn't work quite as well. So my goal was to search the literature for potential treatment options for factor V Leiden. And this led me to a research paper by Omarova et al. In 2014. So Omarova et al., their hypothesis and their research led them to a potential lead as a treatment with fibrinogen. And if you remember, fibrinogen is cleaved to form a fibrin clot. So it has procoagulant activity. Well, factor V Leiden is procoagulant. It wants to clot. So you wouldn't think that putting 2 procoagulants together would make a difference. But we'll see in a moment that it may actually provide a difference. Fibrinogen has 3 monomers, A alpha, B beta, and gamma monomers, and is encoded on the gene FGG. And gamma also comes in 2 different isoforms, gamma A and gamma prime. And the gamma prime isoform has a C terminal of 20 amino acids. And this particular C terminal has a high affinity for the exosite 2 of thrombin, which deactivates thrombin when bound. And if you'll notice the normal levels I've got over here sort of to the side underneath my beautiful picture, that kind of looks like a mouse, but just kind of squints, that's fibrinogen. The normal levels of the isoforms are usually you see gamma A/gamma A in about 85 to 92% of people in the blood, and really it's in the blood. And gamma A/gamma prime you see about 8 to 15%. Now hold on to the fact that that's a little bit less prevalent. And the gamma prime/gamma prime is only seen in about 0.5% of the actual plasma. So the Omarova et al. Observed a haplotype previous to this publication of the paper that I will be referencing. The haplotype was called FGGH2, which is the fibrinogen gene. It had increased APC resistance. Now this is a very similar phenotype to factor V Leiden. And they also noticed that this particular phenotype had lower levels of the gamma prime isoform, so lower than even 8 to 15% or 0.5%, which is pretty, that's pretty substantial, very, very tiny bit. And this observation led to their hypothesis that supplementing a peptide that mimics the C-terminal end of gamma prime could restore sensitivity of the plasma to activated protein C, which would essentially deactivate clotting, which is really what we need with factor V Leiden. So really, they were postulating that perhaps fibrinogen had its own anticoagulant activity as well as procoagulant activity that everybody's mostly aware of. So, the figure. Getting into this, I went ahead and I highlighted very specific because it's shades of gray. And, this is a very light shade of gray. So I decided to highlight it with a color so you could actually see it. But in order to test this hypothesis, they, Omarova et al. Took plasma with and without peptide, which is the 20 amino acid C-terminal that they were looking at, and they titrated it with increasing amounts of activated protein C. And this is basically measuring the thrombin burst. So in this first upper row, in the first column, this is our negative control, or their negative control. Sorry, I promise I'm not taking their data. Their negative control that has no peptide. And this is what you would normally see in a wild type, run-of-the-mill, no clotting issue person. And I want to point your attention to at the 1 nanomolars of APC. Now with the normal plasma, nothing's wrong with this plasma, generally speaking, as you add APC, the thrombin burst goes down. Well, if you add the gamma isoform over here with the 20 amino acid tail, and I don't believe it was specifically gamma prime, but it was mimics gamma prime, all of a sudden you go from a good bit of thrombin to way lower. And the only reason that the first spike is the same is because there's no activated protein C being added. So that really is the only reason. And I did have it highlighted, I think it was like 3 nanomolars, but of course it's like a line. So in order to really show a good appreciable difference, I ended up changing the figure. Now, if you'll notice with the second row, this is the Factor V Leiden plasma that they got from a Factor V Leiden patient. And if you'll note the legend, it's different. They look like the same colors, and I'm sure they are the same shades of gray or whatnot, but it is different. So you need almost at least twice, if not 3 times, the amount of activated protein C in order to mimic the same wild type response that you see with the decrease of the thrombin burst. And this is because Factor V Leiden is less sensitive to activated protein C, which makes sense. So that really is what we see. But if you'll notice, we do have the same similar response and almost an even better response. Although, like I said, it really is a double response. So it's about the same response because we have 2 nanomolars down here and 1 nanomolar, so it's doubled. But we have the same decreasing thrombin burst, which is interesting. So not only does the gamma prime looking isoform decrease or increase the sensitivity of the plasma to activated protein C in normal plasma, it also seems to do this in Factor V Leiden plasma. So that was pretty interesting, and really the conclusion of this overall figure is that gamma prime is a potential drug for Factor V Leiden because it really is such a little tiny peptide. And I do want to also point out that nanomolars is 10 to the negative 9, and this will become important when I show you the next figure. So this next figure, I wanted to really include this because I wanted to show the other effects of the gamma prime peptide because, as I mentioned before, it does have a procoagulant effect. And so this is really showing its procoagulant effect. And they were looking for the rate of activation of activated protein C, which, And so I want to point your attention to the actual legend. Here we're dealing with micromolar. Micromolar is 10 to the negative 6, which is way bigger than 10 to the negative 9. So keep that in your mind for a moment. But as they increase the gamma prime, it slowed down the activation rate of protein C. And they add much higher levels in order to get this effect. So even though technically, with a lot of other papers, because this is really a novel paper, they were mentioning overall that gamma prime really is not very good at making the plasma more sensitive. This is proving that, well, it does make the plasma it does it does hinder the sensitivity of the plasma to activated protein C, but in a very dose-dependent manner. And I do want to really quickly point out that the peptide control over here, because I took it out of the first figure, is really a scrambled control. And really what that means is they took the same 20 amino acid peptides that they used with the gamma prime, and they just sort of mucked them up. They just sort of rearranged them, kind of like fruit basket turnover, and just to prove that this particular 20 amino acid really is dependent on the specific order and not just the fact that it's a 20 amino acid C-terminal peptide bit. So therefore, in lower doses, gamma prime peptide could prove a promising treatment for Factor V Leiden. So it's not a complete cure, and it's not, you know, oh my goodness, this is amazing, let's just give tons and tons. It really is a dose-dependent thing. So, but I really thought it was interesting because I didn't notice the nanometers and the nanomolars and the micromolars until a little bit later. So, really showing how much compared to the first figure that we saw. So in conclusion, there is a need for more effective Factor V Leiden treatment. The fibrinogen gamma prime increases sensitivity of the plasma to activated protein C. The anticoagulation effect of the gamma prime peptide outweighs its procoagulant effect. And fibrinogen gamma prime peptide could be a potential clinical treatment for Factor V Leiden. But there is more research that needs to be done on these intricate processes because, like I mentioned before, it has both procoagulant and anticoagulant properties, which is very fascinating and was not really very touched on before. So I'd like to say thanks to Dr. Kimberly Baker because she was my mentor, and mostly we had a lot of chocolate and tea, and there was some tears involved, and I just was able to go to her for anything, and it's been really lovely to have such a wonderful friend like Dr. Baker. I'd like to thank my mom and my brothers for putting up with me and my weird studying habits and always doing something or running somewhere. I would like to thank Malachi and Rory. Rory's the hamster, Malachi's the rabbit, for really giving me some love whenever I needed it. Even if I had tears, usually the cats will run away from tears, you know, because they're men. And I guess these are men too, but they're not as smart men. So, you know, they were able to not necessarily run away as quickly. I would also like to thank Agents of S.H.I.E.L.D., Agent Carter, The Flash, and Arrow for saving my sanity as well as saving the world. Questions? Yes, Dr. Cadet.
So when you were showing when you were describing the only current treatment right now would be to plasma, I guess, infusions.
Yeah, it's fresh frozen.
So I was just thinking though, why aren't they isolating Factor V? Maybe it's the main question. I'm not a blood person, but why aren't they isolating Factor V from the plasma directly to minimize the hypertrophic effect?
Because as far as my research brought me to understand, it's very difficult to isolate it, although I'm not entirely certain if they said why it was difficult to isolate it, but for whatever reason, and maybe it has to do with how it is secreted, since Factor VIII is secreted as it has two parts to it, but Factor V is only secreted as a monomer. It may have to do with that. I'm not entirely certain, but I didn't actually get a for real answer.
It's like it exists in like more.
Oh, there you go. And it's also very tiny.
Yeah, it's not.
Yeah.
So it's not necessarily a problem.
Which is weird because you would think if you could isolate its buddy, Factor VIII, you could do it with Factor V, but that's not what they've seen. No. Come on, lay it on me. Yes, Dr. Jenny.
So could the peptide be used for people? There's lots of normal clotting problems.
Yeah.
Rare diseases could be used for those as well, or would it only really work with the people with these mutations?
It really depends on where in the clotting cascade the particular factor that you're having an issue with is, because this particular fibrinogen, it really does like activated protein C, but it also makes it more sensitive. However, it really, most of the clotting factor issues that you're going to see is you have you don't get to, the cell doesn't secrete the factors, so there's a degradation before it even gets secreted. Whereas Factor V Leiden, it gets secreted just fine, and it's kind of like a kid out of the playground. You know, it goes out to play, but it doesn't want to come back in. And I'm not entirely certain if there are other diseases that mimic Factor V Leiden where there is an aberrant protein that has been secreted. It may work for them. I didn't really touch on that because I was mostly looking with Factor VIII, and Factor VIII really doesn't have a counterpart quite like Factor V Leiden, but it very well could be a possibility. Anything else? All right. Well, thank you.
That's it, right? Yeah,
Handhelds are really good. How do you feel about it now that you're done?
Good.
I can only imagine.
Let's see. The one for Natasha, she
Actually, has it.
Great.
Thanks.